I'm here. Can you see me? Can you hear me?
I can hear you, Carlos, and now we can see you. So the floor is yours.
Well, thank you very much. I appreciate the invitation to be speaking to you today. I'm sorry I'm not being able to be there in person. This is a really fantastic workshop, and I think a lot of very important things are going to come out of this. So can I have the first slide of my presentation, Julie? Okay, can I have the next slide, please? Well, I start by giving you my disclosures. And one of the things that I'll say is that during the pandemic, I had the privilege of advising a lot of organizations from local government, like the mayor of Atlanta, or the mayor of Phoenix, to the mayor of Savannah, to state government nationally, and working also a lot with industry and with business. And I would say that one of the things that to me is a very important lesson is that the message that got out, it was that it was public health versus the economy. And somehow we were not able to get the message out that public health is important for the economy, and for the economy to function, public health needed to be there. And I think to me that's an important lesson, is that we pitted public health against the economy, when in reality that was not the case, and we were not good at messaging that. The next one. I want to start by talking about Jonathan Mann. Jonathan was a very a friend, a mentor, and the director of the of the Global AIDS Program, the funding director of the Global AIDS Program. Advance the slide, please. And at one talk about a year before he died in the unfortunate crash of Swissair 111 in 1998, in a talk he gave in 1997, Jonathan said, "Our responsibility is historic, but when the history of AIDS and the global response is written, our most precious contributions may well be that at the time of plague, we did not flee, we did not hide, we did not separate." And I would say that one of the most important things that we in infectious disease and public health and many other areas did is that we did not flee, we did not did not separate, we did not hide. We took care of patients, we did what was needed to do. And I think that will be one of the most important contributions we had, and that includes the research contributions. The next one. So I think I just showed this from the New York Times this past week to show that, yes, while the number of cases has gone down, we're not at the peak that we had during the Omicron wave. We're still having about, over 500,000 cases globally, and about 1,500 deaths globally still from this virus. So the pandemic is still ongoing and will continue to be a problem. So we're not over this problem. The next one. And indeed, again, mortality has gone down significantly, and has gone down primarily because of vaccines, but also because of immunity. People have been infected, and as a result of that, there has been increasingly more of an immunity barrier. So understanding what COVID is going to be like in an immune population, I think is going to be one of the most important questions going forward. The next one. But we cannot forget the incredible impact that COVID has had in mortality globally, and the increase in death rates in almost every country, and the excess mortality has been really one of the things that the pandemic has had an impact that none of us predicted back in 2020. The next one. So just to review, this is a very quick timeline of the pandemic in our country. Again, from when WHO reported a novel coronavirus, when the first case was confirmed in the US in January 21st of 2020, the WHO declaring the coronavirus outbreak a public health emergency of international concern, and Brazil reporting its first case in Latin America, and then WHO characterizing COVID-19 as a pandemic in March 11 of 2020, and then how by April 24th of 2020, the launch of the Access to COVID-19 Accelerator happened, and the Operation Warp Speed and many other things happened. So how quickly we went on, the next one, to develop the tools, the necessary tools, and to gear up to do the research that was needed. Of course, the cases started to go up very quickly. You can see that by September 20th of 2020, there was global deaths have reached 1 million. And then, Alpha appeared, and then Delta, and very quickly followed by Omicron. So the evolution of variants is another area that clearly we were not prepared for. The next one. And a lot of things happen, including political involvement, the Supreme Court blocking Biden's vaccine or test mandate for large private companies, a federal judge in April 18th of 2022 avoiding a mask mandate at airports and other air travel. And by May 17th of 2020, the U.S. reaching 1 million deaths. And subsequently, Dr. Fauci and then President Biden testing positive. And by September 1st of this year, the ACIP recommending bivalent boosters. And now by, in December, having the BQ1 and BQ1.1 becoming the dominant variants. And as a result of that, the FDA removing bebtelovimab EUA. So this is a very rapidly changing pandemic. And I think that's also an important lesson that we need to remember is how rapidly things change and how much political interference happened throughout this process. The next one. We cannot forget that associated with this pandemic, we in our country went through a very tough period of violence and systemic racism was brought to the front line. And I think a lot of what has happened and what will need to happen going forward is really addressing systemic racism as an underlying problem in America and something that if we don't do, we're going to be in the same place over and over again. The next one. So where are we in our country right now? So roughly, cases are beginning to go up a little bit. Hospitalizations are also starting to increase. And cases, and mortality is about, roughly about 250 deaths per day. So we're still seeing a decrease in mortality despite an increase in cases, and we'll see what happens over the next several weeks. The next one. But you can see from the CDC indicators that a lot of things are encouraging, except for hospitalizations going up. But I call your attention to the fact that vaccinations that, boosters have not taken as much. Next slide. And in fact, if you see vaccinations in our country, while there was an initial uptake, I think vaccinations have really slowed down, and we have a really small number of people over the age of 60 who have received a bivalent booster. And I think that potentially is one of our biggest vulnerabilities in our country. Next one. Who gets impacted, where the case of COVID, you can see in red here, and who have been the deaths, I think you can see in the blue here. And clearly the mortality has been much, much higher in people over the age of 50, and in particularly people over the age of 65. So again, emphasizing why we need to really focus on people over the age of 50 as a population that we have to target on boosters and other interventions. The next one. The racial disparities on this pandemic, on who gets impacted and who has died of this pandemic, is something that we have to address. I think racial disparities in this pandemic are not new. We've seen them in many other diseases, but racial disparities are a problem that if we don't tackle in our country, we will never be prepared for the next pandemic. The next one. So many things we did right, and I think the development of vaccines was something that we did right. To me, going from where the virus was sequenced and the collaboration, the development of vaccines started, to when we administered the first dose of vaccine. This is a picture in my clinic at Emory, the Hope Clinic of the Emory Vaccine Center. We were involved in the phase 1 study of the Moderna vaccine. March 31st, we injected our first participant. I think this is unprecedented, and this is a product of really lots of resources, but government, industry, community, investigators coming together and quickly doing what was needed to be done. The next one. And for not surprise, 2020 was an extraordinary year for science, and Nature says it very well in this article. And I think one of the successes of the pandemic, one of the things that we did well in the pandemic has been science, and we need to recognize how science really evolved and was done in a very amazing way. Next one. Together with other colleagues, we wrote a paper back in 2021 about where we were in COVID-19, what were the lessons learned, and what were the questions remaining. The next one. And I think we learned a lot of things. We learned about, the importance of pre-symptomatic transmission. We learned about who is likely to transmit. We learned about how aerosols are involved in transmission. So there was a lot of things that we learned. The next one. But there's a lot of questions remaining. And I think we need to continue scientifically to address these questions, and we need to continue to investigate. We need better drugs, we need better diagnostic tools, and more importantly, we need better vaccines. We need vaccines that are going to prevent not only disease, but are going to prevent actually infection, which at this point in time, we don't have. The next one. Together with my colleague and also National Academy member, Dr. Jaime Sepulveda, we are commissioned to do a study by the WHO panel on the response both in Mexico and the US. And we wrote this document that I'm going to highlight here. And again, remember, this was done about 2021. The next one. So I think the first conclusion we had is that the United States lacked effective political leadership in its COVID-19 response at the federal level. And I think leadership really was one of the issues that we really did not have appropriately. I think at the state and local levels, this was highly variable. And the fact that our public health system is not federal, but it's local, I think it's one of the challenges that we will continue to have as we try to respond as a nation to a pandemic. The next one. I think the US failed to act decisively to combat the virus. I think we did a very good job in vaccines, but they were poorly executed, and delays in the execution of public health interventions. And the chronic underinvestment in public health, I think, had significant consequences. The next one. We talked about how minority populations and those living in poverty were disproportionately impacted. The next one. I think the structure of the US healthcare system is fundamentally ill-suited to mount an effective coordinated response to a pandemic. And that, I think, was very clear. And I think looking at our healthcare system is going to be something that we have to do as we go forward. Next one. And as a result of that, hospitals in the US were unprepared to cope with high influx of COVID patients. And we see hospitals now unprepared to cope with the high influx of influenza patients. In other words, it doesn't take a lot to overwhelm our hospitals and our healthcare systems, and because they essentially work at capacity on a continuous basis. And that, to me, is one of the challenges that we have confronting any future pandemics. The next one. I think the US commitment, as I said, to vaccine development was a defining success. I think we had a slow initial rollout, and there was sort of an absence of a coordinated national vaccination strategy. But the reality is that vaccine success needs to be touted as something that was really remarkable. Next one. I think the federal spending that was done to support families and businesses and to protect the American economy was very important. And I think that's something that was really a critical intervention. The next one. But we do need to the US has to take a global leadership preventing a pandemic. Pandemics represent a global security threat and require commitment to everybody to we need immunological equity at a global level. We cannot say, well, we'll take care of our own and not worry about everybody else. Next one. Finally, the virus has evolved over time. And I think the evolution of virus, like this virus has done, is something that, quite frankly, we haven't seen with any other viruses. This rapid evolution has made it really challenging to really understand what works, what doesn't work, and how vaccines are better suited. So we need vaccines that are able to not respond just to one virus, but to a host of viruses. The next one. Even today, at the peak of the Omicron wave, we saw COVID killing Black Americans in rural areas of roughly, 34% higher than it did white people. So racial disparities have persisted in something that we need to re-emphasize. The next one. I think, disinformation and misinformation has been a challenge, and it's something that we have to address, and the National Academies is looking further into this, but something that we all need to consider as critically important when we think about future pandemic plans. The next one. This is the document from National Academies. How do we identify credible sources of health information in social media? These principles are now something that YouTube and other organizations are using in looking and saying what's credible and what's not. The next one. I think communication is another area that I think we failed. We failed to communicate, and we failed because communication, we were not prepared for the digital age of communication. And in this digital age, you need communication to be prompt, to be compassionate, to be honest, to be informative, and to be interactive. And, having a press conference is not necessarily the way to do this in a most effective way. And I think we need experts in communication to tell us how do we do this better going forward. Next one. because effective communication really is critical as part of the pandemic response. And we have to think about how to do this in a positive framing. And I tell people that trust is at the center of communication during a crisis like a pandemic. And that it's important that the communicator be a rock, and that person needs to be reliable, needs to be open, needs to be competent, but also needs to be kind. And I think those are the principles of communication that we need to emphasize as we go forward and we think about who are our best communicators in a pandemic and how do we best, get the message out, because I think failure of communication was one of the biggest failures of this pandemic. The next one. So are there lessons from the HIV pandemic that are applicable to COVID-19? The next one. Because I've been an HIV researcher, I've thought a lot about this. And one of them is that we need to think harm reduction, not risk elimination. A lot of the communication we did was around risk elimination when we really needed to have a risk reduction approach. We needed to eliminate any type of stigma and discrimination. We need a more human rights focus. We needed trust. We lost trust very early on, and we really have not done a good job recovering trust in public health. We have to involve all parties in the response. I think community building is better, and we need to do it all the time, and we need to do it continuously. I think, as I said, information and language are critically important. I think we need to pay attention to the most vulnerable populations. We have not realized that. And we need to not blame individuals for system failures. Resilience is really important. We have to think globally, and we have to think that science and public health require multidisciplinary teams. We have not involved all different disciplines that are necessary in order to respond to pandemics. The next one. So risk is clearly not equally distributed. I think that's something that came out very clearly. And a respiratory viruses rapidly can put pressures in the healthcare system, well-resourced like ours, and take it to the brink of collapse. I think we need to finally invest in public health. We haven't done that, and we need to do it. And we need to realize that pandemics are unpredictable by nature, and that proper preparation and planning can help, but are not necessarily going to immunize us. We need to do a better job to tackle non-communicable diseases. I think we saw how obesity, diabetes, hypertension were risk factors. Well, it's time that we actually address those epidemics as well. And we need to address health equity. As I said, we have to end structural racism as part of our pandemic response. The next one. So in conclusion, we have to anticipate health inequities in every pandemic. We had to create an enabling environment to support behavior change for people. We need a multidisciplinary approach to pandemics. The next one. We need to protect healthcare workers. It has to be really important that we do that. I think humility is essential. I think we need to know how to be, how to recognize what we don't know, and how do we communicate that to people. And finally, we need to remember that that love can be fatal, right? That COVID-19 turned every man, woman, and child into potential serial killer. And there's no fear worse than contracting a deadly illness from somebody you love, or giving a deadly illness to somebody you love. So I think we need to also be able to realize how do we deal with this issue of we as humans want kindness, we want to be able to visit our sick people. We want to be able to hug our family members, our friends, our loved ones. And yet we prevented that. And I think we created a lot of damage by doing that. The next one. So in my mind, HIV researchers were critically important in the response. And Mike Cohen will talk more about this, but how the HIV research networks were rapidly turned into COVID research networks, I think was a very important lesson out of this and really paid off. The way in which research was taken into guidelines was remarkable and influenced care very quickly. And again, the COVID-19 inequities that we have seen for a long time need to be addressed. And we need a global response to a pandemic. We cannot look locally alone. The next one. And with that, I'll end and happy to answer questions at this point in time. Julie, I'll turn it over to you.
So Carlos, I think I'm going to ask you a few questions, and then we're going to turn it over to the audience or any questions that are coming in. So sure. At the end of the slides, I saw that you said, think globally, act locally. So I sort of have been wanting to ask everyone at Emory or in Atlanta, what did you do well, particularly in that local aspect, and what did you not do as well, and what steps are you taking to correct that?
I think Atlanta has a very interesting situation because we don't have a city health department. We have county health departments, and there's at least, the city is formed by 20 counties. So working with different counties is always a challenge, and it's always difficult. But I think that we needed better county coordination. I think one of the things that we did well at Emory is we coordinated across our different hospitals and across the different healthcare systems of the city very effectively. We would have weekly calls in which we will make sure that the guidelines across hospitals were the same, that if a hospital was implementing eye protection, everybody else was, that if a hospital was saying use N95s, everybody else was, if the hospital was saying we're not using N95s, everybody else was. So in other words, that we didn't see different guidelines at different places that would just confuse people and create mixed messages. I think we didn't do a good job continuously communicating to people and doing it in an effective way. I think we did a good job in working with local business leaders. I had the fortune of being asked by the mayor very early on to advise the business community before nothing happened on this. And from then on, the business leaders were rapidly involved in responding to the pandemic, and city leaders really were remarkable in their approach to providing workers support and providing access to testing when available, and providing all sorts of different things. So I think working with the business community is something that we did quite well.
Going to your conclusions, the second one was that we didn't react early enough. We obviously did really well from the sequencing of the virus to moving to research to the vaccine, but what would you single out as an area of scientific research that we did not do early enough, and what should we be doing now to correct that?
So I think that we initially focused very rapidly on vaccines, and we didn't focus as much initially on therapeutics. A lot of our therapeutic studies initially were obviously make sense, looking for people that were critically ill. But it took us a long time to come up with therapeutics for people who were not critically ill, for mild to moderate disease. I think about a paper that Josh Gandhi, John Lynch, and I wrote for New England Journal of Medicine back in September of 2020 on management of mild to moderate COVID, and there was essentially nothing, right? And yet most of the infections were mild to moderate. So doing research and developing drugs to treat mild to moderate COVID should have been something that we did from the very beginning, trying to find antivirals and trying to use them in an effective way. And there was a huge investment in developing a vaccine, but there was not the investment in developing therapeutics. And I think I would say we put all our eggs in the vaccine basket, and would have been great if the vaccine had stopped this, but now that it doesn't, now we wish we had done other things.
And I'll open it up, is you talk about how the structure of the U.S. healthcare system is not ideal for dealing with pandemics. Can you give an example of our system compared to another system and why theirs is better? And then practically, given that we're not going to overhaul the system fast, what specifically can we do to help that issue?
Well, I'll just put the example, for example, not in taking care of patients, but in research. You can see how other countries, like, for example, the UK through the recovery study, they were able to do incredible clinical research because they have a healthcare system. We were not able to do those kinds of studies because we have this fragmented healthcare system. And I think we need to figure out, how do we work with our electronic medical records? How do we work with our information systems that in such a way that even though the healthcare system as such don't work together, at least the data flow works in a different way. And during a pandemic, you can rapidly aggregate data and come up with information. I think if you talk to CDC, they'll tell you that, there's no way for them to know who admitted to the hospital had received a dose of vaccines. Our healthcare systems, our information systems don't talk to each other. And that makes it very hard to do the kind of studies that Israel, Qatar, many other places did. So the US lagged behind in doing the kind of research that was really critically important in understanding how to manage these patients, because we don't have those integrated data systems. Now, I know this is very hard. I mean, everybody tells me that if you know one Epic system, you know one Epic system, and they don't communicate with each other. But we have to talk to those EMR companies and say, now Epic, that dominates the market, and Cerner is the other one. How do we work in such a way that at least we can gather information so we can do the kind of study similar to Recover and others in the future in our country?
So I want to open it up to people. I have other questions, but yeah, I am actually. Yeah, so, okay, thank you. So who would like to ask a question? I can repeat it for Carlos. Or there are also mics on the side of the room. There's got to be someone brave enough to ask. Okay, Carlos, I'll ask. Are you sure? Does anyone have anything?
We do have a question from
Mike.
Oh, there we have one.
Can you argue? You can do whatever you want, Mr. Cohen. Carlos, Mike's going to the mic.
Carlos, those are terrific. Is this working? Yes. Those were
Yeah, I can hear you, Mike.
They were terrific comments, but I do think I have one argument, and that is I don't know how we could have worked on everything any sooner than January of 2020. In other words, Dr. Gruber is here. He was working on Paxlovid from the very first meeting. The monoclonal antibody, Regeneron had already started phase 1 trials in February. So the notion that therapeutics were not being worked on, I never saw anything faster. And Dr. Gruber can speak for himself, but so I would take issue that the species worked at unbelievable, I don't want to call it warp speed, but I guess I'll have to, worked at unbelievable speed. So that's my only argument with your comments, and maybe you...
No, I agree, Mike. And in fact, my clinical unit was doing studies with Regeneron and monoclonals at the same time we're doing vaccine studies. I just think that the way things came together in warp speed and the investment that was done was something that we didn't see in the therapeutic side. That's the point. I think that maybe there were people working independently and companies working independently, but I did not see, at least it wasn't clear to me that there was a true intention to develop therapeutics the way we did in developing vaccines.
I got a quick, Carlos, thank you so much for the great presentation. I'm Jason Newell, and I'm a pediatric infectious disease physician from WashU. I think you mentioned some great points about the lack of vaccines and the lack of uptake, especially more recently to both boosters. I think in the pediatric space, we know that especially in the children less than 5, we're probably about 7% of that age group being even vaccinated in this country. It seems to me one of the biggest issues we've had is access to these vaccines. And the fact that we've made it pretty complicated to even get the vaccines and all the different recommendations. How do we improve access for vaccine for everyone? Because I think if you take a family of 4, for example, you can't go to one place and get all those vaccines for that whole family, especially when we're talking about people trying to just live day to day.
No, I agree with you. I think we don't have in our country, we have traditionally relied on pediatricians to do pediatric vaccines, but we didn't even have a way for adults to get vaccines. I think a lot of the pharmacies, companies like CVS, Walgreens, and others have done an incredible job of making vaccines available. And the fact that you can now get vaccines outside the healthcare system for, not only COVID, but many other diseases, influenza, you name it, I think it's a great advantage. But we need to make vaccine access much easier, and also something that is subsidized, right? We need to be able not to have to buy. I mean, I think was Pfizer said, the COVID vaccine now that becomes stops the government funding stops, it's going to be costing about $150 a dose or something like that. Well, for the great majority of people, they're not going to be able to afford this, and I think having vaccines not subsidized, in my mind, creates enormous challenges in a country where there's huge health inequities and where we have, a large number of the population, large percent of the population who are uninsured. So how do we provide vaccines in a way that is equitable? I think is one of the challenges that we have as a country, not only for children, but for adults. Vaccination is an intervention that should be available, accessible, and free of charge.
Hi, my name is Anna Bento. I'm the science director at the Rockefeller Foundation. First of all, I really enjoyed your talk. It's been a pleasure to hear you speak. I really found very interesting at the beginning when you opened and said it was a shame that there was such a friction between the economy and control of disease. And one of the things that I've been kind of working on with some colleagues has precisely been in this realm of trying to see how you can avoid trade-offs between saving the economy and having an effective targeted control of COVID-19. But in your experience, in a country like the US, where of course there are federal policies, but a lot of the work in terms of control and policies are done at a much lower level, either state or even at a level of a county. How do you feel, or how do you think we can move forward in the place of thinking about coordination? My colleague just before mentioned that for him, the failure had been vaccines, but from my point of view, the biggest failure has actually been a coordination failure. How do you think that can be done in a different way moving forward? Thank you.
Well, I think we need business, we need the economy to understand how the value that public health has. I mean, having healthy employees, having healthy individuals is actually it's good for a corporation, it's good for a company, it's good for an organization. I think that we need to get, putting a lot of restrictions, I think works in a negative way. I mean, I don't think what I did was perfect, but I can tell you, for example, working with, let's say, I'll put you an example, the Atlanta Opera. At some point in time, the Atlanta Opera was the only opera company in the entire world that was still having functions during COVID. And that was because I got together with them and we said, how can we continue to have music and continue to have what we have, but do it in a safe way? And we did all sorts of things. And if you go to the Atlanta Opera website, you'll see, we put the musicians inside this funny looking plastic, boxes essentially. And we did all sorts of things. We did testing. We did all sorts of things in order to prevent, we vaccinated the musicians. We did all sorts of things in order to prevent transmission and yet be able to provide, we did it outdoors and in such a way that the audience could come. So, and that business survived as a result of this. So how do we modify the business practices? How do we incorporate public health into business practices? And we work together with them. But if public health, all it does, it says, you've got to shut down your business, you got to do this, you got to do that, and doesn't give an alternative, I think we fail, because then there'll be backlash, right? Then there'll be people saying, well, you have ruined my business, you have ruined the economy as a result of your public health. And that's not right. So we need public health and business to work closely together. And I think we have not done that successfully. We need business to understand the value of public health, but we also need to have public health understand how business operates and what kinds of things can be done to safely and what kinds of things are not safe enough. And you have to understand, again, it should be risk mitigation, right? We need a risk mitigation approach to dealing with these issues.
I'm the unfortunate bearer of the news that we have time for one more question, and then those who are waiting in line can maybe ask the next panel. So you're up.
Ken Kester from IAVI. Carlos, great talk. A lot of discussion on vaccines and therapeutics, which I think we all recognize the importance. I wonder if you can comment on the ability, the need, or the opportunities to also better harness clinical research. So as the pandemic progressed, novel approaches to ventilation, dealing with issues of hypercoagulability and other things like this were not necessarily well diffused throughout the medical establishment, and a lot of different types of approaches were adopted without a clear sort of coherent response. And I wonder if you could speak to that separate from the sort of the pharmaceutical issues.
Well, I think, again, I go back to having sort of a well-established research platform, right? I think the Brits showed us with Recover how this can be done, and they can test it all sorts of things. And they were able to tell us, look, steroids work very quickly. And they were able to tell us what works, what doesn't work in ways that we were not able to do. I think we did, except for network-related studies, a lot of the other studies were done by one-alls, by this investigator doing that and this investigator doing that. And there was not really a coordinated approach. So we need to have a sort of a way to create a research platform around this kind of issues that actually brings people together in different ways nationally. Because if we don't do that, then we're not going to be able to do the kinds of studies that are necessary. I mean, to me, it is amazing how also we did many one-off studies that actually were contradictory to each other, and then that created confusion in adapting approaches. Some people say, well, anticoagulation works, and it doesn't work, and all the studies were criticized because none of them was a well done, perfect study. So how do we get studies done up and running quickly in a changing environment, and when guidelines and what therapeutics are changing? And I think that to me is the other challenge, right? Even right now, thing about antivirals, they were approved and they were done, studies were done in an unvaccinated population. Now we're using the oral antivirals in a mostly vaccinated population. And we still don't have enough data about, when to use them, how to use them, are they effective, are they not, et cetera.
Thank you, Carlos. That was really great hearing from you, and I would like to meet you sometime in person.
Yeah, I wish I was there. Take care, Julie. Janet, thank you.
Dan and Elizabeth, want to come up and introduce